Now moving towards our second talk, I would request Dr. Milap Mashru for our second talk, that is an interesting case in a critical care medicine.
Um, Good evening, respected seniors and friends. Uh, I, would, I would like to discuss one case which we came across recently. There is 15 years old boy came with history of pain in right thigh since last 7 days. He had high grade fever since last 3 days, and there was a shortness of breath since last 1 day. Past history, there is a history of travel to a resort in Sarsangir with history of blunt injury in the right leg while playing in a swimming pool. Primary treatment was taken at local physician and referred to Synergy Hospital for further treatment. On arrival, patient was febrile, tachycardia, tachypnea, blood pressure was fine, saturation was borderline. He was having cramps in the lungs, CVS as soon as to normal, there was no murmur, CNS, patient was conscious oriented, abdomen was soft. Local examination, right thigh and gluteal region was having signs of inflammation, swelling, redness, and tenderness. So, clinical diagnosis was right thigh cellulitis with sepsis. Now, the blood investigation, if you see first, total count was high, CRP was high, create was okay, sodium was low, albumin was low, PCT was high. So, this full-fledged sepsis. So we went ahead with the investigation. First, we have done the HRCT thorax. There was bilateral minimal pleural effusion and multifocal discrete small to medium size area of nodular opacity, and some of them is having cavity. So this was suggestive of septic emboli. USG was showing hepatosplenomegaly. These are the CT thorax. Here you can see there are cavitation in the nodules, and the location of the nodules are at the periphery, so it is suggestive of septic emboli. So for the treatment, septic emboli, so we wanted to rule out infective endocarditis. We took 3 sets of blood cultures 15 minutes apart. 2D echo was done in ER. There was no any vegetations. Antibiotic, after drawing the blood culture, we have started with the meropenem, linezolid, and daptomycin because we were suspecting some gram-positive infection because of the septic emboli. And we have planned for the MRI right thigh with both hips and screening of the spine. MRI has suggested there is a abscess in the right internal obturator muscle. The size of the abscess is 63 by 35 millimeters, so 6 by 3 centimeters small abscess. There is effusion in the right hip joint. Surrounding muscles of the hip like piriform, proximal part of the right hamstring, left gluteus on the other side, all are having inflammation, but there was no any collection there. Even the bilateral iliopsoas is showing inflammation. So above findings are suggestive of myositis with secondary adjacent inflammatory changes. Here you can see this is the abscess. Here it is not there. Here also very beautifully abscess is shown here also. And here is the abscess and surrounding edema. So now what to do? Surgeons were involved, discussed with the general surgeon and orthopedic surgeon. They were in the opinion that there is a pus, it has to be drained. But if we open this chap, then it will be a highly morbid surgery. We may have to open the hip joint. So we decided to do a CT guided pigtail drainage. It was 9 p.m. in the evening. I called up Dr. Vikas Jain, interventional radiologist. He came without delay. He did CT and USG guided 12 French pigtail insertion in the pelvic region on the right side. And the pus, what we have aspirated, we sent the pus into the blood culture bottle. And hardly 10 to 15 ml pus came out. Kept in the ICU with all the supportive care. Here you can see the drain. Here also you can see the drain. Now within 36 hours we had this report of the blood culture. All 6 blood culture bottles were positive. It was methicillin resistant Staph aureus, heavy growth. Here you can see it looks like a community acquired Staph aureus. Sensitivity was clindamycin was sensitive, rifampicin was sensitive, linezolid sensitive, and daptomycin also sensitive. First culture what we have sent in the blood culture bottle, that also grew the same organism, MRSA. So further course we continued the same line of treatment except meropenem was de-escalated to ciforaza sulbactam. Patient was co-managed with ID physician Dr. Krutar and general surgeon Dr. Rajan. In between, patient required some oxygen. Repeat blood culture was done on day 4. It grew the same organism. USG was done on the day 4. Drain was in situ and size of the collection has reduced. Pus from the drain was coming thinner. The quantity of pus is not much, but the quality has become thinner. On the day 8, patient was improving, but we wanted to rule out whether is there any other emboli in elsewhere. So we did a PET CT because patient was continues to have fever intermittently. In the CT, PET CT, the extent was in the lung and right hip area only. No elsewhere any embolization. Rifampicin was added, and on day 9 we did a blood culture which was negative. By this time patient has become afebrile, patient has started walking. We have discharged patient on day 11 with the drain. Daptomycin, linezolid and rifampicin total we have given for 18 days. After the 7-day follow-up, we have done the repeat MRI. MRI was fine. Residual abscess was there, so we have removed the drain. Linezolid was continued for total 4 weeks. This is the PET scan report. You can see the hypermetabolic lesions are in the lungs and in the right hip area. There was patchy involvement of the bone also. But luckily, patient has clinically improved and we did not have to open the joint. And slowly patient improved. You can see from CRP 300 on the day of discharge, it was around 70. So the final diagnosis was a case of pyomyositis with patchy osteomyelitis with right internal obturator muscle abscess with septic emboli in the lung. The source could be the spread through the scratch or damaged skin after the swimming in the pool and because of the strenuous exercise what he has done in the swimming. So review of the literature. This is very beautiful review article, pyomyositis in children by Dr. Sanjay Verma in the Pediatric Infectious Disease Journal. Some of the point from this review article. This pyomyositis is more common in the tropical areas like in India and Africa. Previously, it used to be called tropical myositis. It is a disease of adolescents and young adults. More than 90% of cases, it is community-acquired methicillin-resistant Staph aureus. There is 2 associations is there. One is the history of muscle injury, direct blunt trauma, or history of any strenuous exercise. In various studies, it has been shown that it is common in the soldiers also because of the rigorous exercise. And there is some history of bacteremia, some cut or some wound. Because of the bacteremia and the association of exercise, this Staph aureus, they will infect the bruised muscle and there will be deep abscess. Usually 3 stages. First is invasive stage, then is the suppurative stage, and third is the septicemic stage. Our patient was in septicemic stage. It is more common in pelvic and lower limb muscles. USG and MRI are preferred investigations. Drug of choice, all gram positive means vanco, tico, linezolid, dapto and clindamycin. but because of the side effect of the vancomycin and the when you use the vancomycin, there are high chances of development of resistance. So in this patient, we have started with the daptomycin and linezolid. Daptomycin does not cover the lung, so for the lung, we have added linezolid. Most of the patient recover with the percutaneous drainage. If patient requires surgery, there will be high mortality and morbidity. Now, swimming pool bacteria, I have searched on the net, the first article which I came across. If the swimming pool water is not properly chlorinated and pH is not maintained, the most common organism is Staph aureus. There is one study done in Iran. Iran is in limelight now. They have done a study in their community pools and jacuzzi. Around 30% of the isolate from the pools were Staph aureus and 10% of there is MRSA. So, a scratch area of skin after swimming in the pool can potentially be a point of entry of MRSA. MRSA can survive on the surface like locker room benches, towels, and in the swimming pool water if the pH is not maintained and it is not properly chlorinated. So to minimize the risk of MRSA infection after swimming, it is recommended to shower thoroughly before and after swimming. Keep any cuts or wounds covered with waterproof bandage and don't use pool if you have any skin infection because it can spread to some other person. Don't share your personal items like towels and ensure the pool maintains proper chlorine and pH levels. So to conclude the case, what are the learning points? In critical care, it is always hit hard and hit fast. Put your best foot forward. Initial appropriate antibiotics save life. You can always de-escalate later, as we have done. A stitch in time saves 9. Even a small drainage of pus will help for the speedy recovery. The source control is always a cornerstone of sepsis management along with the timely antibiotics. And in this type of patient, which are on the borderline zone, whether you have to go in, you have to do the surgery or percutaneous drainage is fine. Watchful waiting is the key. Repeated imaging along with the close clinical and blood investigation monitoring and multidisciplinary team approach are the key for favorable outcome. If we operate in such condition, there is high morbidity and possibly a mortality. And last not but the least, always swim in a well maintained pools, and if you have some skin cuts or abrasion, avoid swimming. बाकी तो जब जब जो होना है तब तब सो होता है. વિજયભાઈને કંઈ ખ્યાલ નહોતો કે બીજા દિવસે શું થવાનું છે. Thank you and continue to enjoy the journey called life. Thanks.